We described the pharmacokinetic and pharmacodynamic properties of antimicrobacterial agents. Now let's differentiate between latent tuberculosis infection and active pulmonary tuberculosis infection. The infection begins by inhalation of bacteria through nose or mouth and then into the lungs. They typically go to the upper region of the lungs because oxygen content is higher at the top of the lungs. Although lower lobes can also get infected, but upper lobe infection is more common. Don't confuse this with upper respiratory infection. Upper lobe is still in the lung and is considered lower respiratory infection. Once the bacteria get into the alveolar space, they encounter the alveolar macrophages. The immune system starts to kill the mycobacteria. If the first line defense fails, the mycobacteria can penetrate the lung interstitial tissue and enter the lung parenchyma. In the alveolar space, the dendritic cells will present these mycobacteria to the lymph nodes for T cell priming. Then the lymphocytes, both B cell and T cell, will come and find the mycobacterial in the lung parenchyma and contain the infection. As a result, a structure called granuloma will form, and inside the granuloma, the mycobacteria can reside and start to replicate, or they can remain inactive, which leads to latent tuberculosis. Because the mycobacteria are contained in the granuloma, someone with latent TB is not infectious. Now, what can happen over time is that the granuloma grows and gets bigger. At some point, it will not be able to contain the mycobacteria anymore. At that point, the granuloma will actually rupture, and then the person becomes infectious because the person can cough and transmit the mycobacteria to other people. At this point, the person is considered to have active tuberculosis. The mycobacteria can also go to other parts of the body and cause extrapulmonary manifestations. Let's take a look at different spectrum of tuberculosis manifestations. So we can, at each stage, look at tuberculin skin test, interferon gamma release assay, culture, sputum smear, which is basically staining, acid-fast staining, and then if the person is infectious, has symptoms, and if the treatment is preferred. So someone with innate immune response is someone who has actually cleared the mycobacteria. So therefore the TSD and IgRA will not test positive, and obviously there will not be anything on culture or smear or sputum smear. This person will not be considered infectious and will not have symptoms. Now, if someone had already been exposed to mycobacteria and as a result of T cell priming had immune response, on a subsequent exposure to mycobacterium, the immune system can actually get activated and clear the virus. For someone like this who will not be considered infectious and will not have symptoms, nothing will be on cultures and the sputum smear will be negative. However, the TSD and IgRA will test positive because of this immune response. Now, this can transition into someone who actually has latent tuberculosis. So this is someone whose immune system could not handle the mycobacteria, and this person will have granuloma. Because the granuloma will contain the infection, this person will not have symptoms. So this is not symptomatic, and the person is not considered infectious. The TSD and interferon gamma release assay will test positive in this person, but the culture and smear will be negative. Now, this can transition over time to active TB, and in between latent tuberculosis and active TB, there is a phase called subclinical tuberculosis, which is very difficult to diagnose. And these are basically the patients that could sporadically be infectious as these granulomas start to release the mycobacteria. And they could have mild symptoms, or these patients could actually be asymptomatic. And these patients will have TSD or IgRA positive, and sometimes the culture can be positive, and unfortunately the sputum smear is usually negative, which makes it difficult to catch. And of course, when it comes to active tuberculosis, the patient is typically symptomatic and the symptoms can be severe. The person is considered very infectious and everything will be basically positive. So TST, IgRA, and culture. And the smear is often positive. So a small portion of patients can have a negative smear, but most patients will have a positive. And treatment is recommended for someone with active TB. And if you can catch subclinical TB, the treatment is recommended. And for latent tuberculosis, it's basically preventive therapy. So the person is not considered infectious, but we do give them treatment in order to prevent progression into subclinical and active TB, because these two not only have severe consequences for the person, but they can also lead to transmission of infection to other people. Here are the recommendations from 2017 IDSA CDC guidelines for diagnosis of tuberculosis. In general, the interferon gamma release assay is preferred over the tuberculin skin test, especially in these four populations, including patients who have received the BCG vaccination. Most other countries have routine vaccination of BCG, and because this can lead to false positive skin test, it is recommended for these patients to have the IgRA used over TST. Now, having said that, IgRA is typically more expensive and also may not always be readily available. So the TST is an acceptable alternative if the patient does not have access to IgRA. Now, these two tests will test positive in both latent tuberculosis as well as active tuberculosis. So really what distinguishes active from latent is really the absence of symptoms. So if someone has tested positive but they do not have symptoms, and on a chest x-ray, if the chest x-ray is normal, that's really how you diagnose latent tuberculosis. There are two assays that are commonly used in the United States for interferon gamma release assay. So the quantiferon TB gold as well as the T-spot, and these tests are very easy to do. They typically either test positive or negative or intermediate. When it's intermediate, it's reasonable to just repeat the assay in order to get a conclusive result. And of course, for tuberculin skin test, which is the cheapest way to test, there are a couple of limitations. One is that the patient has to come back in order to get the results read. So, you cannot get the results the same day. As well as anybody who had the BCG vaccine, they can have a false positive. Another issue with tuberculin skin test is that in some people who are infected with Mycobacterium tuberculosis, the ability to react to tuberculin may wane over time. So when given a skin test the years after infection, these people may have a false negative reaction. Now, one thing we have seen is that when you give the skin test, the tuberculin skin test, it can actually may stimulate the immune system, which is referred to as a boosting. So for people who get tested routinely, like healthcare workers, it is recommended to get a two-step skin test. And what that means is that you give the first test, and if the first test is negative, because it could be a false negative due to waning of the immune, the person's immune response, it is recommended to repeat that test within 1 to 3 weeks, because the first test will actually boost the immune response. And then the second test that's given 1 to 3 weeks later, if it tests positive, then you can actually catch more latent tuberculosis by avoiding a false negative. Now, if that second test is also negative, then you can actually rule out a latent tuberculosis. Now, when you diagnose latent tuberculosis infection, not everybody is likely to transition into an active TB. Some populations are at higher risk. So the higher risk of progressing from latent to active is typically children aged less than 5 years. HIV infection, people who take immunosuppressive therapy, so such as organ transplant patients, And patients who had abnormal chest x-ray consistent with prior TB, so if they've had active TB before, they're more likely to have TB again, as well as silicosis, which is basically a form of occupational lung disease caused by inhalation of crystalline silica dust. So these patients are at higher risk of progressing to active TB, so they are more likely to benefit from treatment of latent tuberculosis. Whereas other patients, they might be at intermediate risk of getting active TB, and really the evidence hasn't demonstrated a clear benefit if you treat latent TB. Now, for diagnosis of active TB, obviously, it depends on the presence of symptoms suggestive of tuberculosis, as well as a chest X-ray showing cavities or other signs of active TB. An important part of diagnosis of TB is the acid-fast bacilli or AFB smear microscopy. And in general, it is recommended to get 3 specimens every time there is a smear microscopy performed. In addition, it is recommended to get a mycobacterial culture, both liquid and solid media. There have pros and cons. It takes longer for solid media to show growth. However, you can get morphology on solid. So both liquid and solid are recommended. Nucleic acid amplification test is recommended, and it is routine in practice. One of the common assays used is the expert MTB RIF test, which can basically tell you the same day if the patient has Mycobacterium tuberculosis. It can also test for resistance against rifampin. So that's why you see RIF here. Now, the traditional susceptibility testing from the mycobacterial culture may take up to 8 weeks for the results to come back. So because up to 8 weeks, we may not know if the regimen that we're using is susceptible or not. That molecular testing that gives you the rifampin test the same day is really important for these patient populations. So including someone who has been treated for TB in the past because the Mycobacterium tuberculosis could have developed resistance as a result, or if someone has contact with patient with multi-drug resistant TB or HIV infected patients. It's important to know very quickly if rifampin is susceptible or not, because if it's not, then an alternative regimen needs to be used.